Alberto Jaramillo. We will be talking about characterization of oscillatory and aperiodic resting state EEG spectrum in neurodegenerative diseases, a multicentric study.
So, good evening, everyone. Just give me a quick second so I can set on my laser pointer in here, which I think it's more friendly for the persons in the online transmission. And yeah, as introduced, my name is Alberto Jaramillo-Jimenez, and I'm a medical doctor holding now a postdoc position at the Stavanger University Hospital in Norway. And today we're going to talk about how can we characterize the oscillatory and the aperiodic part of the resting state EEG spectrum in different types of neurodegenerative diseases. This is a multicentric study which has been possible due to the European DLB consortium, which I am part of. And these are my disclosures. And just to mention, if you want to scan the QR code in here, you can download the slides and follow the presentation. This will appear also in the end of the presentation if you don't have enough time to scan it now. So let's start talking about brain rhythms, which is, I think, it's quite interesting for us in this session. And I want to pose your attention into the posterior alpha rhythm. This has been robustly described since the beginning and the conception itself of the EEG by Hans Berger. And here we can see one of the examples of the alpha waves we can see in the posterior electrodes of the resting state EEG. On the bottom, you can see a sinusoid reference oscillating at 10 Hertz, and on the top, we can see different the traces with the brain rhythms of the posterior electrodes in the son of Hans Berger. This was Klaus at 15 years old, and I just annotated how many peaks can we count in each of the epochs of the EEG. And as you can see, this type of alpha rhythm oscillates between 8 to 11 in cycles per second, as conceived in this first publication by Hans Berger. But he also noticed that the normal alpha rhythm, in addition to appear when we close the eyes, it was abnormal in dementia patients. And here is another citation by Hans Berger, where he mentions that these alpha waves are prolonged in senile dementia. This was the naming we do have in that time. And he was observing that these senile dementia patients particularly exhibit slowing down of this alpha rhythm. And this did not happen during healthy aging, which is very, very important. And as you can see in here, the number of oscillations or cycles per second is quite reduced compared to Klaus, his son. And here is a simulation, because all the time I speak about spectral analysis, but not so many people is understanding what is spectral analysis. So in EEG, we do have different electrodes, as you can see in here, and we do have time series, which is basically we do have voltage changes across time. Here, I just made an example where we have the number of peaks across 1 second, and here are 10 peaks. But when we start avoiding counting peaks and we start characterizing how many oscillations do we have in a period of time, we can transform our signal from the time domain, as you can see here on the top, to the frequency domain, as you can see here on the bottom. And we can start discussing about rhythms, because now we are in the domain of the frequencies, right? And as mentioned, the most important and most common rhythms that we do have in our resting state EEG when we close the eyes is the alpha rhythm, right? In addition, we can also have other sources of oscillatory activity, such as the delta activity and the beta activity, which can be even created by noise or by the heart activity. But if we look at this power spectrum, which is the actual spectral analysis of the EEG, and we look at it in a log scale, we can see that when we introduce some arrhythmic components on the EEG, we can start to see this kind of a slope, which is quite important, and I will go back to it in the next slide. And here are the two EEGs we saw before, and I'm passionate about imaging processing as well, so I reconstructed the vectors from the pictures of the original papers on Hansberger, and I modeled what was the signal so I can make a spectral analysis, because in Hansberger time, it was not possible to perform a spectral analysis using the methods that we do have now. So we do have on top the normal EEG, which will be in green, and in red, the dementia EEG that we have seen before. And here is the spectral analysis of those Hansberger EEGs reconstructed now. And here you have in gray the sinusoid, the reference sinusoid he used to quantify how many oscillations were the reference. And as you can see here, there is a peak at 10 hertz, which indicates, yeah, the sinusoid oscillates at 10 hertz is the reference. Here we have in green the EEG from Klaus, his son, 15 years old male, and the peak was also oscillating around 10 hertz, which is the thing that we expect that happen. But in red, we do have the patient with dementia, which showed the slowing down of the peak. And as you can see, the peak is centered around 5-6 hertz. But in addition, I want to highlight that if we smooth this and we fit the aperiodic methods that Peter presented in the first talk, we can see that the power spectrum is not only constituted by the oscillatory part, but also by an aperiodic, non-rhythmic part. And if we separate the oscillations from the non-rhythmic part of the EEG, we can see that there are some differences in the non-rhythmic part of the EEG. So it's not only to focus on the oscillations, but also in the non-rhythmic aperiodic part of the EEG. And this is quite important because the oscillations can be affected by two main phenomena. The first one is the frequency shifting towards lower frequencies, such as theta, and power reduction, which is another common thing we find, and it's a decrease in the height of the peak. But in addition, there are some novel papers presenting that the change in the slope, in the aperiodic slope, can be representing excitatory and inhibitory balance abnormalities, and also changes in the broadband firing of the neurons. And this is particularly relevant because if you look at these two papers in here, the participants with dementia with Lewy bodies and alpha-synuclein-like dementias, they show a very, very steeper aperiodic activity compared to other non-alpha-synuclein types of dementia. So, can we trust on these papers I have shown you before? I don't think so, because most of the times we do have small sample sizes on EEGs. And in this study, they mentioned that most of the EEGs used for clinical research in psychiatry are very, very small sample sizes, and it compromises the statistical power and also the generalizability of the results. So what can we do? We can pull a lot of data from different places, and that could be an option, right? But if we start pulling data from different amplifiers, different centers to get a larger sample size, we can start observing these clustering effects that can be even created by the amplifiers. So if we use different scanners in different sites, we can start seeing some differences just due to the use of different amplifiers. So it's the amplifier, the one that is creating some differences on the EEGs. But fortunately, we can statistically control for these differences and align our data so we can make them comparable and get a very, very big sample size in terms of the EEG studies. And we have published this paper validating, sorry for the pixels, but you can go to the paper, it's in clinical neurophysiology. We benchmarked different statistical approaches to align EEG features, right? And we realized that compared to the non-aligned data, there is a lot of things that we can reduce and we can control these scanner-related differences, right? So taking all those things into account, our objective was to characterize the oscillatory and aperiodic part of the EEG in different types of neurodegeneration, but mitigating these batch effects in a multicentric study. So basically, we took data from 639 patients from different sites, 11 sites, 8 countries in the world. We ran a pre-processing, automated pre-processing. I encourage you to read the paper. I will post you the preprint link in a while, so you can go and check the details on pre-processing, but everything was automated. I do not like to bias the results by my clinical interpretation of artifacts. And this was basically data from open sources, but also data from in-house clinical studies that we are conducting in Colombia, my hometown, and at the European DLB Consortium. We basically took all the data, extracted the posterior power spectrum, and aligned the data. This is how it looked before the harmonization and after harmonization. And after that, we use the same method Peter was presenting in the beginning to characterize the oscillatory and the aperiodic characteristics of the signal, particularly in what we call the extended alpha band, which is taking the frequencies from 5 to 14 hertz. And after that, we wanted to characterize the different patterns across different clinical phenotypes. We do have healthy controls, MCI-AD, AD, PD, a group of MCI Lewy body dementias, which included Parkinson's disease with MCI and MCI with Lewy body pathology, and a big group of Lewy body dementias, including Parkinson's dementia and dementia with Lewy bodies, and frontotemporal dementia. And we assess this characterization through different types of statistical testing so we can get like valid and robust results. And just to mention the method we use for alignment and harmonization is a method we borrowed from imaging, and basically it's a method that allows us to handle the big issue of having one site contributing with a single type of diagnosis, because we want to preserve the effect of diagnosis, we want to preserve the effects of age and sex, but we want to rule out the effects of site, right? And in this harmonization method, basically, we residualize our power spectrum, taking into account all these covariates, and this particular method is good when you have data coming from a site where only one diagnosis was available, because if you try to discard the side effects, it will be the same info as you have in the diagnosis, so this method can handle with this. I encourage you to go and read it in details. So basically, it allows us to make the data comparable and align the data, preserving the effects of age, sex, and diagnosis. And here are some of the sample characteristics. As you can see, these are the results of age distributions by site and age distributions by groups, clinical phenotypes, and across the whole sample. And here are some of the details in terms of gender by site and gender by diagnosis, as you can see in here. I'm not going to focus on the details on that because our design was not a priori made to have comparable populations in terms of age and sex, so we use these as covariates for some of our analysis. And here is the results of the batch harmonization. First, we can see that the distributions are quite comparable when we compare the unharmonized and harmonized data. And if we look at the power spectrum, we can see that there is an improvement in terms of alignment. If we look at the PCA distributions of the data across sites, we can see that when we harmonize the data, the distance across these centroids is reduced. And if we test this with the statistics, we can start even modeling all the power spectral densities using this method, which is a spline regression method, where we try to get the mean of each of the sites and compare if there are differences associated with the site itself. And as you can see in here, the harmonized data show lower differences across sites. So we are correcting the scanner effects, and it is the same results we can obtain with this mass univariate test cluster across frequencies. We are reducing the side effects, right? But we need to preserve the effects of diagnosis. And here we can see that the harmonized data show bigger differences across diagnosis. So we are preserving the information across diagnosis, but reducing the potential confounder effects of the site. This has been also validated with mass univariate tests. And we can start looking at the big differences across all the phenotypes in this plot. I don't want you to go in depth for all of these plots, but I just want to highlight the first thing. In purple, you can see that the Lewy body dementia groups, they always show shifting towards lower frequencies, particularly pre-alpha band, in all the comparisons with all the groups. And in terms of aperiodic activity, the LBD shows very, very steeper exponents compared to the other groups, highlighting again that they are showing a very, very high aperiodic activity. And if we compare it with Alzheimer's disease, we can observe that the main change in Alzheimer's disease is the power reduction on the extended alpha band. Here is what we got when we compared pairwise the spectral parameters across all the diagnoses, and I just want to point out that the center frequency in dementia with Lewy bodies was significantly different across all the subgroups, and also in terms of the aperiodic activity. So dementia with Lewy bodies shows a reduction in the oscillatory peak frequency, but also steeper aperiodic activity. And if you compare with Alzheimer's disease, they only show significant differences in power. We conducted linear regressions as well, and these linear regressions shows that even if we adjust for age or sex, or if we take the spectral parameters only, the center frequency and the aperiodic parameters are quite important for dementia with Lewy bodies differentiation, with AUC ROC above 80%. So to conclude, batch effects are quite important. You need to look at them, and in Lewy body dementias, we do have more abnormalities, both oscillatory and aperiodic, whereas in Alzheimer's, there are mild abnormalities, mainly characterized by power reductions. There are several limitations of the study, but I invite you to look at the preprint that we have published, and in the preprint, you can find more details about the things I have missed due to the time. So with all of this and no more delays, I think I need to move to the next slides, not without thanking the EDLB Consortium for making this possible, and the Global Brain Health Consortium and Red Lat for all the discussions that we do have that have made this effort possible. This is my contact information in case you want to have some questions, and I think there's no more time for questions for now, so thanks for your listening.
Thanks a lot. No, we're out of time, so.